Billy went through a bit of asthma, I thought maybe I'd just take a moment to set the stage of why asthma and research in asthma is so critical. So asthma now affects more than 30 million Americans and probably more than 100 million worldwide. Amongst these 30 million, probably 25 to 35% are children. And in fact, the incidence or prevalence of asthma is increasing far greater in children now than it is in adults. Most of the current therapies, any of you who have asthma, for example, taking inhaled corticosteroids, recognize that these are simply therapeutic or symptomatic treatments, and they're not disease modifying. They don't change the natural history, the natural course of the disease. Importantly, corticosteroids do not prevent the long-term loss of lung function. So although they may improve symptoms and so on, they don't alter the course of the disease. Part of our conceptual basis for asthma is thought to be an imbalance in how we respond to stimuli, and that is we produce cytokines, proteins from cells that may be pro-allergic or protective. The pro-allergic cytokines, we sort of lump them together under the Th2 or T helper 2 subset, whereas the Th1 cytokines may be protective. And bacterial cell products, many of them such as containing CpG oligonucleotides, may modify the allergic response by altering the balance between Th2 and Th1. These bacterial cell products actually stimulate a Th1 response. So, as many of you may be aware and suffer, allergy is a systemic disease. It's a disease that we say is atopic, and it can affect the sinuses, the nose, the lungs, the skin, such as an atopic dermatitis. And now, even increasingly, perhaps the highest prevalence are effects on the gastrointestinal tract, eosinophilic esophagitis, and eosinophilic enteritis. And we talk about an allergic march, where kids begin initially in early infancy with atopic dermatitis, then food allergy, and afterwards they develop allergic rhinitis and asthma. So it sets the stage to think about trying to intervene with a therapy that may prevent this natural or so-called allergic march. And this is just a picture of an asthmatic airway, and the asthmatic airway, whoop, I did something wrong.
It's the red one.
The red one. So this is asthma in its worst case, a lot of mucus plugging, a constriction of the airway, a lot of smooth muscle proliferation, and pretty significant inflammatory response surrounding the airways, both the large and small airways. And the goal is to prevent these things from happening, to maintain normal airway function. So when we think of targeting asthma, we have gene and environment interactions. And as many of you should know, you can't choose your parents. I always say you can choose your in-laws, but you can't choose your parents. And so we are dealing with a very predominant gene effect. For example, if a mother has asthma, 40% of her children will have asthma. If both parents have asthma, 70% will. So we have a very strong genetic susceptibility. And on that genetic susceptibility, we have the environment. And we're now aware that most allergic asthmatics can trace the origin of their disease to the first 2 to 3 years of life. So these early life experiences become absolutely critical. And we know that asthma occurs much more frequently in the developed countries than in the underdeveloped countries. Large family size is protective. Rural farms with livestock are protected. And in the westernized countries, such as we live in, maybe with the vaccinations, the types of vaccinations, perhaps we've created an increased risk. And this risk, it plays into this Th2, Th1 imbalance. So where we have an increased exposure to allergens, indoor lifestyle now much more than before, high concentrations of allergen, and the 4 major allergens associated with asthma in the United States are house dust mite, cockroach, particularly in the inner city, cat, and alternaria, a form of mold. So this imbalance may be the result of our environmental exposures. And we talk about the Th1, Th2 imbalance. The allergen triggers a Th2 response at the expense of the Th1 response. So our thinking in asthma has been to try to separate distinct stages. The induction phase, when we're initially as infants exposed to allergens, where we start the asthmatic process, and the later or maintenance or progression phase. And the question was whether or not pathways that were responsible for the induction phase were also responsible for the maintenance phase. And we know that the triggers are in fact, in this induction phase, allergen and viruses, particularly in infancy. All of you have experience with respiratory syncytial virus, the croup virus, occurring very early in infancy, may be playing a role in this phase, and obviously other things playing a role in the maintenance or progression phase. And so we have genetic factors, we have exposures, we have relapse and remission, but in fact we go on to disease progression. So our work, beginning several years ago, was thinking about the bacterial cell products and trying to think how we might maneuver the immune system away from a pro-allergic response to this protective response. And we examined the role of microbial heat shock proteins. They're a group of proteins produced by many cell types, but in response to environmental stressors. Importantly, they were associated with the generation of these Th1 type responses. And we worked with one particular one, which is mycobacterial heat shock protein 65, as an immunostimulator that may be responsible for Th1 responses. And I guess I should take a step back, and when we talk about this increasing prevalence over the last 4 to 5 decades of asthma, one of the interesting aspects is that people who did studies, epidemiological studies, had associated this increase in asthma prevalence with the cessation of BCG tuberculosis vaccination. And one could link when we stopped vaccinating kids at birth, those my age had many scars. In fact, I'm from Montreal and I had to have a positive TB test to go to medical school. And I was scratched about 6 or 7 times, but never, and to this day, have never converted. But there were studies published to suggest that stopping BCG was in fact associated with this increase in asthma. And studies are now in effect with infants going back to do BCG. But one of the BCG components is this HSP65. And as Vili showed you, we use a sensitization and challenge model that the mice are sensitized, then they're challenged via the airways, and we can measure airway function just as we measure in the human, the response to inhaled methacholine. And our initial studies, I will just go through very quickly, but these heat shock proteins showed a very significant reduction in the development of airway hyperresponsiveness. We showed certain ones, such as the one from leprosy, that mycobacterium was highly effective. If we look at eosinophils, which is a hallmark of the allergic response, you can't see very well here, but there are a lot of eosinophils in the control, but the HSP65 treated animals, they're virtually abolished. When we look at mucus production, particularly with this purple staining, this is the control, you don't see it. The goblet cells are hyperplastic here. Again, it's virtually normalized here. And so on. And IgE, the allergic antibody, is also decreased, particularly the specific antibody to the allergen is decreased. Importantly, this heat shock protein inhibited Th2 cytokine production, the Th2 cytokines being IL-4, IL-5, and so on, but increased the interferon gamma. So we did switch to a Th1 production phenotype, and Th2 production, as shown here, was inhibited. So it looked like in our earlier studies that HSP65, this heat shock protein, prevented the development of airway hyperresponsiveness, reduced airway and tissue eosinophilia, switched the phenotype from a Th2 to a Th1 phenotype, and prevented goblet cell metaplasia and mucus production. In fact, when we compared it to the CpG oligonucleotide, the HSP65 appeared to be much more effective. Interesting, and in line with what Villy and Brad had talked about gamma delta cells, it looked like some of these effects were at least mediated in part by this gamma delta T cell phenomenon. But there were some key unanswered questions that were critical to the commercialization of this particular patent. We wanted to know whether or not the relative potencies of heat shock protein, how were these potencies different depending on where they were administered? Because in an asthmatic, we know we're never going to get in there before the initial exposure to allergen. We're not going to be able to treat a 6-month-old or a 12-month-old infant. We're going to do this more in adults who are in that maintenance or progression phase. So the question is, would it work after we've experienced a lot of allergen challenge? We also wanted to know, were these effects allergen specific? Were they specific to the allergen we use, or would they work regardless of the allergen? Because you can imagine if you're allergic to house dust mite, cat, and dog, we're going to have to give each one as a cocktail, and it becomes a very complicated therapeutic approach, as opposed to saying one size fits all and we can suppress all allergens. And that was what we set out to do under the grant that we were lucky to secure. So originally the data were, we showed that heat shock protein was given early on in this acute model. But the question became, what happens if we sensitize and challenge and then come back and do a challenge later on so that the lung is fully allergic? Lung responses suppress, they die down a bit. But then we do a single, what we call provocative allergen challenge, very much like we do in humans. We take an asthmatic, we give them an allergen to try to provoke things to see what the pathways are. So the goal was to determine at this stage whether or not in a fully allergic lung, these heat shock proteins would be as effective as they were when given prior to the challenge here. And in fact, as you can see here, using the heat shock protein to Mycobacterium leprae or to the heat shock protein to TB, that these effects in the secondary model were in fact very effective in suppressing airway hyperresponsiveness. So even in the fully allergic host, the development of airway hyperresponsiveness was prevented, and we markedly decreased airway eosinophilia. Now, all of you know that if you're going to use an injectable drug for asthma, it's going to be very difficult to get a good market. There's in fact only one drug that we use today on a regular basis by injection, and that's anti-IgE or Xolair, that one receives a shot every 2 or 4 weeks to suppress the allergic response. So we went on to begin to think of putting the heat shock protein directly into the airways, much as you use your inhaled corticosteroid in a canister. And as you can see here, we've just begun these studies and working with the doses because we're about 100 to 1,000-fold lower than doing it this way, that even giving the heat shock protein intratracheally in these previously allergic animals also now suppress the development of airway hyperresponsiveness. So we're now thinking about, is asthma preventable? Is it curable? We know we have certain treatments, but as I mentioned earlier, our best treatment, corticosteroids, has little to no disease-modifying effects. And we know that the disease begins very early on And we have a very narrow window of opportunity to try to manipulate the immune system. And hopefully, using this heat shock protein approach, we certainly will learn more. We will learn whether the benefits will be observed, as I suggested here, regardless of the timing of administration, that they'll extend beyond the allergens that are being used at the initial exposure, but will have a general applicability to sensitization to the wide range of allergens. And hopefully, and for Brad's sake, these data will increase the opportunities for commercialization. Thank you very much.